Right. Good afternoon. Let me thank the organizers, Dr. Ajit and Dr. Pradeep, for conducting this wonderful conference. And I'd like to congratulate the audience also who is here at this time. Thank you. So I've been given this topic, actually a question that I had to answer, kind of. Can Biapenem play a rescue role and save Meropenem for the future? I was a little confused about how I have to go through this. So I did a little bit of research on this and, well, let's see how it goes. But first, let me say there are no conflicts of interest for the study that I want to declare. We'll just go through what Biapenem is first. Biapenem is parenteral broad-spectrum carbapenem. It's been recently approved in India, only last year, for the management of complicated urinary tract infections. But it's an old molecule. It's been with us for the last 20 years or so. It's been used in the East, mostly in Japan, Thailand, and China for sepsis, lower respiratory tract infections, UTIs, intra-abdominal infections, and genitourinary infections. So we have quite some data from that side. When you basically classify carbapenems, you can classify it into three groups. The first group, according to their activity against non-fermenters and activity against MRSA. The group 1, we have one molecule that's available here, that is Meropenem. Group 2 is the commonest group that we use, Imipenem, Meropenem, Doripenem, and Biapenem now. They are active against non-fermenters like Pseudomonas, Acinetobacter, but they have no activity against MRSA. And group 3, they are still under trial. Hopefully we'll have soon. These drugs have activity against non-fermenters as well as MRSA. So we'll be talking about Biapenem mostly, which is in the group 2. Pharmacokinetics and pharmacodynamics. Some of the early carbapenems like imipenem are not stable to hydrolysis by the human renal dipeptidases and are co-administered with a DPHI inhibitor like cilistin. But Biapenem is a very stable molecule. It's not hydrolyzed. It's even more stable than Meropenem. So it can be given alone. And it's got very good penetration into the tissue after IV administration. Let's see what it does once it reaches the tissue. It's got a really broad spectrum of antibiotic activity. It is active against gram-positive cocci, gram-negative bacilli, and anaerobes. Actually, it's got better activity against anaerobes than metronidazole, but it is definitely not active against MRSA or Enterococcus faecium. Are there any special properties or better properties compared to other carbapenems? It does have a very low seizure threshold compared to other carbapenems, especially Meropenem or Panipenem, or even other beta-lactams, even cefazolin. It's probably because Biapenem, it has a low potential of Biapenem to inhibit the gamma receptor binding. It also has post-antibiotic effects. It's not very common to have post-antibiotic effects in beta-lactam molecules, but Biapenem and Imipenem do show post-antibiotic effect against both gram-positive and gram-negative bacteria. Excellent tissue penetration and maybe a little better effect against Pseudomonas than other carbapenems. It's probably slightly better against biofilm-forming strains, and possibly it is because Biapenem can escape the efflux mechanism of express pump metabolism of Pseudomonas. Well, what about studies? There are a lot of studies, mostly from, again, Japan and China mostly, that compared Biapenem to other carbapenems, basically Imipenem and Meropenem. And most of the studies have found that it is non-inferior. And there's a meta-analysis that I got that looked at the clinical success in treatment of patients. They looked at different studies that had lower respiratory infections. You can see on the top, no difference. Complicated urinary tract infections, again, no difference. Intra-abdominal infections, also no. Overall, the diamond in the bottom, you can see absolutely no difference between other carbapenems and biapenem in effectiveness of treatment. What about the mechanism of action? Most beta-lactams act similarly. It has to go through the bacterial cell wall. It does not diffuse easily, but it has to go through certain porine membranes, porine proteins in the outer membranes. It has to transverse the periplasmic phase, and then they acetylate the penicillin binding proteins permanently. And these penicillin binding proteins are very important for the formation of the peptidoglycan cell wall. And once that formation is stopped, the cell walls dissolve and the bacteria dies. Why is this important to know? Because this is how the mechanism of resistance of bacteria comes. There are slight differences in the mechanism of resistance in gram-positive versus gram-negative bacteria. If you look at gram-positive bacteria, it's basically because of changes in the PCBs, penicillin binding proteins, which makes them less susceptible to the binding of carbapenems. Other mechanisms also exist, but against carbapenem, that is the most common. But gram-negative bacteria have multiple ways to escape resistance. One is a loss of membrane porins, so that the antibiotic cannot enter the cell. The second is expression of transmembrane efflux pumps, which actively pump out antibiotics so that it will not harm the bacteria. And the most important mechanism is beta-lactamases or carbapenemases, which block the antibiotic or destroy the antibiotic. We have many carbapenemases that are coming. So let's have a look at how carbapenemases, okay, this little bit, okay, that's better. How bacteria or how the separate antibiotics act against or how the different carbapenemases act against the antibiotics. If you look at the top, that's the NDM there. Generally, the recommended breakpoints is different between the European and the American cities. The CLSI has a different breakpoint. They have actually decreased the breakpoints, and now they have come to 1. MIC of 1 is supposed to be resistant for bacteria. Now, if you look at the top there, that is NDM or New Delhi metallobacterolactamase. You can see this around 7. MIC of biapenem is around 7. That means these bacteria are actually resistant to biapenem. But when you look at the others, the MICs of the other drugs like doripenem or meropenem, it is much, much higher. So basically it means biapenem is slightly more resistant to hydrolyze by NDM than other carbapenems, but it's still resistant. What about other beta-lactamases? If you look at WIM or if you look at IMP, metal beta also, biapenem seems to be more resistant to hydrolyze than other carbapenems. When you look at other group of carbapenemases like OXA, again, carbapenem seems to be more stable than other carbapenems, other beta-lactams. Except against, say, KPCs. KPC carbapenemases seem to act on beat Biapenem much easier than other carbapenems. So, is there a benefit? Maybe, because the MIC of Biapenem is much lower. We might be able to use Biapenem with a higher doses, or maybe infusion of Biapenem, so that we can get higher MICs in the body. And in that case, we might be able to act against metallo-beta-lactamases because they are much more stable. But then we need more studies on that. Studies are ongoing now for higher doses. So till we get that, we still don't know, but that looks like a very promising way to act against metallo-beta-lactamases, which is a big problem in our country. Other way for Biapenem is to compare, to add a metallo-beta-lactamase inhibitor to Biapenem. Many candidates are under study, but none have come to the bedside yet. So, in short, Biapenem is a very broad-spectrum carbapenem, got excellent tissue penetration, and it is as good as other broad-spectrum carbapenems, second generation or second group broad-spectrum carbapenems. But for this question, can Biapenem play a rescue role and save Meropenem for the future? I'm not so sure. About the rescue role, maybe. There is I just told you about how we can do that, higher doses maybe, or maybe a metallo-beta-lactamases. So there might be a role to use Biapenem in a rescue role, but can it save Meropenem for the future? It looks unlikely because Biapenem is also a carbapenem, and as you see, when you use a carbapenem, selection pressure goes into the bacteria, and it selects out carbapenemases, and generally these carbapenemases cross-react with other carbapenems. So if you are selecting out Biapenem resistance, most likely it will be resistant to Meropenem also. So unlikely that it's going to preserve Meropenem for the future, but maybe there is a rescue role. Thank you.